I'd just like to start by welcoming everybody to our October Canadian Cancer Survivorship Research Consortium rounds. I'm really pleased to have Eric Antonin here to present his project, which is his master's project on entitled EX-CIPN, a phase 1 trial of an exercise-based rehabilitation intervention to treat persistent chemotherapy-induced peripheral neuropathy. So Eric is a master's student, as I said, at the Institute of Medical Science at University of Toronto. I'm a supervisor, but he's working also as a kinesiologist in our team. So he's also a clinician and sees patients clinically. So I'll just pass it over to you, Eric. And so the way the structure works is Eric will present for the next sort of 30 to 40 minutes or however long you need, Eric. We have an hour here. And then leave some time at the end for discussion, questions, comments. So hopefully we'll have some of those at the end.
All right. Thank you so much for the introduction, Jennifer. Hi, everyone. I am Eric, and today I'll be presenting my master's thesis project, as Jennifer mentioned, EX-CIPN, a phase 1 trial of an exercise-based rehab intervention to treat persistent chemotherapy-induced peripheral neuropathy. The learning objectives for this presentation are to provide a background on chemotherapy-induced peripheral neuropathy and the current research with exercise-based rehab, to provide an overview of the EX-CIPN intervention, study design, and methods, and to present the progress and learning points with the study up to this point. So I'll just start with a bit of background on peripheral neuropathy itself. Chemotherapy is a necessary component to cure many common cancers. However, it can induce many different changes to cell structure and function, resulting in toxic effects. Chemotherapy-induced peripheral neuropathy is one of those prevalent adverse effects of many chemotherapy agents, and it can develop at any point during chemotherapy receipt or occasionally after the treatment is completed. CIPN is estimated to be present in 2/3 of patients who receive neurotoxic chemotherapy, and acute CIPN generally improves over the first 3 to 6 months following treatment. However, in 30 to 40% of patients, CIPN signs and symptoms, such as neuropathic pain or decreased sensation, can persist for months or years post-treatment, and this number is even higher in patients treated with specifically taxane and platinum-based chemotherapies. Although the exact pathophysiology of CIPN is unknown to a certain point, there are a few hypotheses on certain mechanisms that could lead to this neuropathy. Firstly, these chemotherapeutic agents from both taxane and platinum-based treatments have been found to bind to mitochondrial DNA. By binding to this DNA, these agents impair the replication and transcription of the DNA, which can impair the physiological function of the mitochondria themselves. This impaired function can in turn lead to some decreased cellular metabolism and increased oxidative stress, and this can cause altered excitability in the neurons, ultimately leading to many of the neuropathy symptoms that we see. A second mechanism that arises is ion channel dysfunction. Chemotherapeutic agents such as platinum-based agents can have a direct effect on sodium channels in the peripheral nerves. These agents can slow sodium channel inactivation in motor neurons, potentially leading to pain sensations in the area of those nerves. Further, these agents can induce neuronal hyperexcitability that decreases the expression of many of these potassium channels, which can also lead to pain in these same areas. And finally, another mechanism related to CIPN is the activation of inflammatory mediators. Again, these chemotherapeutic agents can directly affect the function of glial cells, which are certain cells tasked with supporting neurons and maintaining their environment. These agents can cause glial cells to release and elevate the presence of different pro-inflammatory cytokines, and this increases the presence of these cytokines that can activate different nociceptors in the peripheral nervous system, which are in charge of initiating the sensation of pain. So when these pain initiators dysfunction, pain can result when it isn't supposed to be there. As CIPN is considered a predominantly sensory neuropathy affecting the distal limbs, this sensory impairment can result in different symptoms such as pain, numbness, paresthesia, being a tingling or burning sensation in the hands or feet, temperature sensitivity, and proprioception issues. The presence of these sensory symptoms can then lead to some functional impairments, including static and dynamic instability, gait disturbances, and increased appendicular muscle weakness, resulting in physical deconditioning and an increased risk of falls. It's also important to note that falls risk in cancer patients with CIPN is nearly doubled when compared to those without it. Currently, there are no evidence-based approaches for preventing CIPN, and symptomatic treatment options for established CIPN, including pharmacological treatments, are limited and of some uncertain benefit. Pharmacological agents that are effective for the symptomatic treatment of diabetic and HIV-related neuropathies, such as tricyclic antidepressants and anti-epileptic drugs, require more caution when used for adults with cancer and have shown negative results with CIPN specifically. Further, duloxetine, which is currently one of the only recommended pharmacological agents for the symptomatic treatment of CIPN, has shown limited benefits in clinical trials and has not been compared against all types of cancer or chemotherapy. Other commonly used neurological agents, including gabapentin and pregabalin, have been tested to prevent or treat CIPN in clinical trials, but based on their results to this point, their use is not recommended yet outside of these trials. There are also many different side effects to medications like these, and given their limited benefits shown so far, cancer survivors tend to attempt to limit any further required medications after treatment. And this lack of benefit from pharmacological treatments then led to the emergence of more research on non-pharmacologic interventions. Exercise-based rehab interventions have been shown in the past to be effective for managing many common side effects of treatment and enhancing functional abilities in individuals affected by cancer, both during and after treatment. Recent evidence has also shown that exercise is feasible and may be an effective intervention for different forms of peripheral neuropathy and for patients experiencing CIPN specifically. In order to alleviate symptoms of CIPN, exercise may work through several neurophysiological mechanisms, such as the induction of an anti-inflammatory environment, increasing the supply of blood, glucose, and oxygen to mitochondria, by affecting psychosocial processes. And you may recognize that these mechanisms all work in an antagonistic way to combat the potential causes of CIPN that I mentioned earlier. While the evidence on exercise-based rehab for CIPN is still modest and varied in terms of different interventions tested and outcomes used, there are still encouraging positive effects on the CIPN symptoms. In a study using an intervention similar to the EX-CIPN intervention, very promising results were reported for many different CIPN-related outcomes. This study presented an at-home 10-week muscle strengthening and balance exercise program for cancer patients currently receiving chemotherapy who were found to have CIPN. As seen in the graph on the left here, after completing this exercise intervention, patients improved their neuropathic pain significantly when compared to a control group. Similarly, as seen in the graph on the right, symptom experience as well as neuropathy life interference also improved significantly when compared to a control. These findings presented the potential effectiveness of exercise in reducing some of the CIPN symptom burden. But despite this preliminary evidence in the field, such as the study, no strong recommendations have been made yet by any professional organizations regarding the use of exercise-based interventions in CIPN symptom treatment. Although there is promising literature out there, again, on these interventions, it is held back by low study quality and a lack of definitive rigorous trials with neuropathy pain and symptoms as the primary endpoint. Also, the incorporation of behavior change theory and techniques, which is recommended in the development of rehabilitation interventions where patients are adopting new health-related behaviors, such as exercise, have not been used in a CIPN population as shown during a recent review. And further, most people with cancer report a preference for exercising at home if provided with appropriate support and guidance from an oncology exercise professional, as this can erase the many barriers of attending facility-based programs. Regardless of these findings, no studies have looked at a remote intervention for the delivery of exercise-based rehab programs in persistent CIPN. So, to address these gaps, we developed a 10-week exercise-based program for cancer survivors with persistent CIPN that is delivered remotely, incorporates behavior change strategies, and uses neuropathy-specific exercises to target CIPN symptom areas. The primary objective of our study is to determine the EX-CIPN intervention is feasible, acceptable, and safe in post-treatment cancer survivors experiencing persistent CIPN. And the secondary objective is to obtain some estimates on the effects of the EX-CIPN intervention on CIPN symptoms, pain, CIPN-related disability, and different physiologic outcomes, including upper and lower body strength, balance, gait speed, and functional capacity. So now I'll move on to a bit about the study design and methods. Before I get into the actual intervention itself, I wanted to briefly touch on the development of the exercise portion of the intervention. When developing the base exercise program, we based the program design off of the clinical recommendations surrounding exercise in CIPN. As seen in this chart, the recommendations touch on many different forms of exercise for these patients, including balance, cardiovascular, and resistance training. And on top of this, they also give recommended durations of activity and frequency that we could build the program around. These recommendations provided a more broad understanding of what forms of exercise would be beneficial to the population and help to formulate the sort of base aspects of the program itself. With the base of the program built on these recommendations, we were then able to expand on them by using some of the previous evidence, such as the study that I touched on earlier regarding CIPN. By using these different exercise programs from successful exercise interventions, such as the one on this slide, we were able to identify more specific exercises for the CIPN population. And these studies provided us with exercises that were useful to the CIPN's population specifically, such as extremity targeted exercises, in order to fill out the program to best suit patients with CIPN. This then leads me to the EX-CIPN intervention itself. Each participant firstly will receive an individualized progressive exercise program. The program will aim to reach at least 150 minutes of moderate intensity aerobic exercise per week, resistance exercises 2 to 3 times per week, and flexibility and stretching, as well as neuropathy desensitization exercises daily. It will also contain exercises throughout targeting the CIPN symptoms specifically, and the exercise program will then be revised and progressed by kinesiologists during weekly scheduled check-ins throughout the intervention, and it'll also be supported by the PhysiTrack app to provide participants with the exercise descriptions and videos from home. These are some specific examples of exercises within the program in both the resistance and flexibility components that target neuropathy symptoms in the upper and lower extremities. The resistance exercises on the left help to target and strengthen the hands and feet and the muscles surrounding them. Resistance exercise number 1 is a forearm exercise that we use to build muscle in the forearm and wrist. And resistance exercise 2, or the towel grab, strives to improve toe flexion by asking patients to grab a towel with their toes. The flexibility exercises on the right focus on nerve flossing and desensitization techniques. Flexibility exercise 1, the wrist extension, focuses on the upper extremities by stretching the wrist and hand out in order to help release the ulnar nerve, which runs from the shoulder to the fingers. Flexibility exercise 2 is sciatic nerve flossing, which targets the sciatic nerve that runs from the lower back down the leg and into the toes. Nerve flossing helps to mobilize these nerves to relieve pain and can also promote general strength and flexibility. And finally, flexibility exercise 3 here is a desensitization exercise for the nerves in the feet. This specific exercise uses a textured ball to provide the feet with a new stimulus that they're not used to. And this specific one targets the heel, but we also provide similar exercises targeting the arch and ball of the foot. Also, as I mentioned earlier, balance is impaired heavily in CIPN, and this can lead to a higher falls risk even when compared to other cancer survivors. Due to this increased risk, we felt that including balance exercises in the program was very important for this population. And here are just a couple examples of some of the exercises we use. These exercises provide a shorter hold alternative to different things like single foot stance activities or less demanding approaches to some different balance exercises so that these patients with impaired balance can still train their proprioception and build foot strength even if they have trouble holding the stance for a longer period at the beginning. And then these exercises can be progressed as we go through the program. And finally, the many sensory symptoms of CIPN can make it difficult for cancer survivors to continue with exercise on their own and can affect many of their aspects of physical functioning, ultimately leading to physical deconditioning in these patients. And this is why it was also important to include resistance exercises for different upper and lower body major muscle groups to build strength on top of those neuropathy symptom specific exercises. Core exercises such as the upper body exercise 3 here, as well as the lower body exercises on the right, are especially important for this population, as core exercises focus on building that core strength, which is not only beneficial to their physical conditioning, but also stability, which is a large issue in CIPN. And further, the lower body exercises here are important as they can help to rebuild strength in the appendicular muscles. As I mentioned before, appendicular muscle weakness, another issue that is common with CIPN. The second aspect of the intervention that we have is remote monitoring. Participants will be asked to wear a Fitbit for the duration of the study, and these Fitbit devices will be used to monitor patients' physical activity. The assigned kinesiologist will have access to Fitbit data in order to monitor these metrics, and fitness trackers such as the Fitbit can also promote behavior change and allow self-monitoring in this population. And finally, from weeks 2 to 9, participants will also have scheduled remote check-ins and health coaching calls with their assigned kinesiologist. The addition of this component is important as it keeps participants accountable and provides an opportunity for specific tailored feedback and social support. During the calls, the kinesiologist reviews and progresses the participant's exercise program as needed. They also discuss and develop goals and identify any potential barriers that the participant may have to the program. The RKINs delivering the intervention are trained in motivational interviewing and incorporate the assessment and promotion of intrinsic motivation and development of self-efficacy by using a collaborative problem-solving approach with these participants. And motivational interviewing has been shown to strengthen motivation for change and increase physical activity in many populations with chronic conditions, including a cancer-specific population. The specific behavior change techniques that we use through the intervention are listed in this chart here. Goals and planning is implemented through those discussions that I spoke about, as well as discussions on identifying barriers and how to problem solve for those. Monitoring is implemented through the use of Fitbit and PhysiTrack. Social support is also demonstrated through those remote person-to-person check-in calls. Repetition and substitution through the repetitive exercise prescription and progression that is monitored by the kinesiologists. And this can promote many behavior change techniques, including behavioral practice and habit formation. And finally, self-belief is developed again through the social support and reassurance at weekly check-ins. In terms of recruitment for our study, potential participants are identified by clinic staff and asked if they're interested in learning more about the research study. In addition to this active clinic recruitment, an email address or telephone number is available on information flyers to connect participants to study staff, and these flyers are distributed in clinic waiting areas. The study flyer can be seen here on the right and includes information about the study, what the intervention entails, and some of the inclusion/exclusion criteria as well. The study itself is designed as a multi-method pilot study for cancer survivors experiencing persistent CIPN. After recruitment, these individuals complete their first baseline assessment, or T1, which consists of an in-person physical assessment and questionnaire package. After their baseline assessments, participants all complete the 10-week intervention and remote check-in calls. And immediately after completion of the intervention, the participants complete another assessment at 10 weeks, or T2, also consisting of that physical assessment and questionnaire package. And finally, 3 months after T2, or at 22 weeks, participants complete their final assessment, or T3. 40 participants total will be recruited to the study. The inclusion criteria for the study requires patients to be 18 years or older and have been diagnosed with any type of cancer treated with curative intent. There's no minimum dosage. Participants must be 6 months or more post-completion of chemotherapy, have the presence of neuropathy presumed to be due solely to chemotherapy, currently engage in less than 90 minutes per week of planned moderate intensity aerobic exercise, and have no current plans for chemotherapy in the next 6 months. Individuals will be excluded from the study if they had pre-existing neuropathy prior to the start of chemotherapy or are currently enrolled in a cancer rehab or exercise-based program. It's also important to note that participants can be on maintenance oncologic therapies that are not known to cause neuropathy, and participants can also use medication or different complementary therapies, such as acupuncture, for neuropathy symptoms, as long as these interventions have been unchanged over the 6 weeks leading up to the study and their symptoms of CIPN still persist. They will also be asked not to change or increase the dose of these medications or therapies during the study itself as they are enrolled. Now I'll move on to the outcomes of the study. The first primary outcome is feasibility. Feasibility of the intervention and methods will include recruitment and eligibility rates, retention and attrition, intervention adherence, and safety. Firstly, accrual rate will be assessed based on consort criteria through a screening log that tracks data collected of all screened patients. Eligibility screening will be performed to identify eligible consented and eligible non-recruited individuals with their non-recruitment reasons documented, and the number of participants consented and enrolled will be tracked each month. Retention rates at each study time point will also be monitored. Retention rates will be calculated as the proportion of participants that attend each assessment time point, T1, T2, and T3, and we'll also examine the rates of complete and missing data as well. Adherence to the intervention will be assessed through their health coaching call attendance, Fitbit usage, and self-report completion of weekly exercise plans, which will also be determined during those weekly calls. And finally, safety will be assessed throughout the study, and all adverse events will be scored on the CTCAE version 5 and documented during weekly appointments and at follow-up assessments. The second primary outcome is acceptability. To evaluate acceptability and further refine the program in the future, we ask all participants to complete a post-study survey at T2 to provide feedback on their experience in the study. We also conduct in-depth semi-structured qualitative video interviews with a random subsample of 10 to 15 participants. This interview will help us to gain some feedback on different program components, how participants engaged with the program, in what ways the program impacted their lives, different topics along those lines. And all interviews will be conducted using a semi-structured interview guide to address feasibility and acceptability issues specific to the intervention. And all these interviews are recorded and transcribed. The first of the secondary outcomes is the patient-reported side of the outcomes completed in the form of a questionnaire package, again, at all of those different assessment time points, T1, T2, and T3. The numeric pain rating scale seen on the right here is used to measure participants' pain level at each assessment on a scale from no pain to the worst pain imaginable. On the other hand, the EORTC CIPN 20 questionnaire asks patients if they've experienced certain symptoms or problems related to CIPN in the past week in order to assess their CIPN symptoms. And the CIPN RODS questionnaire asks patients how easily they can complete certain everyday tasks that can be commonly hindered by CIPN in order to measure their CIPN-related disability. And the physiologic secondary outcomes will also be performed at each of those assessment time points, but in the form of a physical assessment. These physical assessments, again, will be run in person by a kinesiologist. Firstly, the grip dynamometer, as seen on the top right here, will be used to measure upper body strength through grip strength. The sit to stand test, pictured on the bottom right, will be used to test lower body strength. The SPPB balance test will measure balance, and the gait speed and 6-minute walk tests will be used to assess functional capacity. This chart here just gives a recap of where all of the measurements for primary and secondary outcomes take place. Again, during the first, second, and third assessments, all participants fill out the questionnaire and complete the physical assessment. And after the second assessment is complete, participants fill out that post-study survey, and the 10 to 15 participants will be selected to complete that qualitative interview in the time before their third assessment. Data analysis of the primary outcome feasibility will be evaluated as study feasibility and intervention feasibility. This will use descriptive statistics and will include the number and proportion of patients who are eligible and reasons for ineligibility for patients who aren't, the number of patients who provide consent and reasons for declining if they don't, attrition rates at each time point and reasons for dropout if they do decide to drop out, and capture of outcome data at each time point, as well as missing data items. Intervention feasibility will be assessed by examining Fitbit and PhysiTrack usage and the virtual check-in attendance. The primary outcome of acceptability will be evaluated through a thematic analysis of the interview data. Analyses will be primarily deductive with a number of categories that we pre-select to align with the main program components that we have, as well as different program strengths, weaknesses, and areas of improvement. Once the initial coding is complete, the interviews will be read and once again, any additional codes will be derived inductively. So we have the deductive codes to start, and then any that come up while going through the interviews will also be added. Themes will be generated by a close examination of those codes, the relationships between them, and discussions with the research team. For the secondary outcome, capture rates of the patient-reported outcomes will be assessed and described to inform future sample size calculations. Analysis will not be powered, and the goal of the analysis is to estimate just the effect size and 95% confidence intervals from baseline to follow-up. And all the data will be analyzed when all recruitment and data collection has been completed. The study is significant in the field currently as the number of cancer survivors is rising due to improvements in early detection and treatment of cancer, and with 2/3 of these survivors set to develop CIPN, and 30 to 40% of those people expecting CIPN symptoms to persist for months or years post-treatment, the need for effective interventions is higher than ever. As there are very few current treatments available, new treatment strategies are needed to allow these patients to improve their quality of life, function, and return to their social activities. And based on the current research, a virtual exercise-based rehab intervention is a promising and accessible intervention for those patients. Now, moving on to the progress with the study so far. Currently, the study has 49 referrals, 20 of those being eligible, 17 being consented, with a couple scheduled for a T1. We've had 5 participants decline due to interest in other programs or living too far from the clinic. 9 have been ineligible, 1 was treated non-curatively, 4 completed greater than 90 minutes of aerobic exercise per week before starting with the program. 3 didn't experience enough symptoms of neuropathy on the DN4 interview, and 1 had diabetic neuropathy prior to treatment. There are currently 15 participants who completed the T1 assessment and 5 who completed T2. The 5 participants that completed T2 showed promising improvements in physical assessments. And from a quick look at some of the questionnaires, some participants also seem to show some slight symptomatic improvement. However, it is just 5 participants, so still a very small sample there. Monthly recruitment numbers can also be seen in the bottom right. Currently, as you can see, we had 3 in April, 13 in May, 8 in June, 8 in July, 12 in August, and 5 in September. So I'll expect to have around 70 referrals by the time recruitment finishes, which would hopefully allow for a number of active participants closer to that 40, which our goal is at the end of the study. And just to talk about some learning points or takeaways that I have so far from my experience in this study. Firstly, the exercise, neuropathy-specific exercise that I've gotten the most positive feedback about is the foot desensitization exercises with that textured ball, which I showed a picture of briefly earlier. Depending on the symptoms that these participants present, they report that either it relieves tension in the feet or it helps to give them some sensation on the bottom of the foot in places where they normally have numbness. And because of these different things, most of these participants choose to complete this exercise daily or even multiple times a day so that their feet can start to adjust to that new texture and sensation quicker. I've also noticed a commonality between many participants that I see that when their job requires the use of a lot of fine motor skills in the hands, such as typing or playing an instrument, their neuropathy in the hands is much more improved when compared to the feet at 6 months post-chemotherapy. This allowed me some insight on different potential exercises to add to the programs, such as squeezing balls of different difficulty, such as stress balls or tennis balls, throughout the day to kind of activate those fine motor skills in the hands on a more regular basis than you normally would if you don't work in one of those jobs that requires it. And finally, many participants have mentioned that they have become so used to some of their neuropathy symptoms that it is very difficult to tell whether they are improving, worsening, or staying the same. For this reason, some of the subjective measurement may be more difficult for them, as they've had a hard time kind of keeping track of how their neuropathy feels week to week. And many of the questionnaires ask the intensity of neuropathy symptoms or how the symptoms are affecting daily activities within sort of the past week only. However, since the participants can't recall what they wrote on the initial questionnaires, when writing follow-up questionnaires, I have seen some variability in their answers from the first 2-second assessment so far. So we'll see if that continues. And lastly here from me, I just wanted to thank and give acknowledgement to my PI, Dr. Jennifer Jones, who introduced me today, my co-PI and co-investigators, and also the team at Elixir for all of the help so far with the study. Thank you very much.